Picture a counselor in a small North Carolina clinic, listening to stories and learning things you don't hear in the classroom. A few steps into the future, and that same voice is steering safe abortion programs globally, and today, directing EngenderHealth's projects in roughly 100 countries. What you'll hear across the next 2 episodes is how this leader used career pivots to sharpen her crisis instincts, how those instincts ignite when funding disappears, and what's really at stake. From PHI Media, I'm Purva Mehta, and joining me for this conversation is someone building the bridge between policy and practice to advance sexual and reproductive health and rights, Traci Baird.
You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content.
Welcome, Traci.
Thanks, Purva. It's fun to be here.
It will start at the very beginning of your journey, kind of going down memory lane with your first post-secondary experience at Stanford University. You majored in human biology with a special focus on women's health. How did that degree kind of shape the way that you approach your reproductive rights work today?
So I actually went into college thinking I was going to study Latin American studies and was ambitious enough to think that I could take a upper level class the beginning of my freshman year, and it didn't go well. It was way over my head, and I realized through the course that it wasn't the political systems of other parts of the world that really interested me. It was the people and the lives of the people, and especially the health of the people. And a pivot to human biology and thinking about women's health, looking back, it looks like a straight line from all of my volunteer work in high school, which was all about health. I worked as a peer educator. I was involved in advocacy around access to information on health, advocated with our school board to get HIV education into my high school, because this was in the early days of the AIDS epidemic. And so when I shifted to human biology, everything sort of started fitting into place. And the idea of going into public health felt very natural to me. And it was a way of combining my interest in preventing health problems with all of the other social sciences, understanding people, understanding communities, understanding policies, understanding history, economics. I mean, it's really a masterful blend in terms of a field. And it meant that I didn't have to pick and choose quite as much. I could pull it all together.
And one of your earliest professional stops was at the Medical Care Center, which was a pretty small women's health clinic in North Carolina. You started as a patient counselor and then became assistant director quite quickly. How did the counseling of patients teach you something that the textbooks never really could?
The humanity of it, right? I mean, when I was studying, and I studied issues of addiction and sexuality in women's health, that was the specific focus of my human biology major. And so I had taken the courses, I had read the books, I had read the articles, I had done a research project in college on medication abortion even. But then being in a clinic that was offering abortion and contraception services, I realized just how personal as well as how technical the issue is around abortion. I mean, abortion and contraception works how it works. There's biology to it, but the people make it different for everyone. So whether I was talking to and providing support to a teenager who was pregnant through incest, or a university faculty member who could not parent another child and yet had become pregnant, the individuality of each situation, each person, was very meaningful to me. It meant that we had a technology and services that could meet the needs of many different people, but each for very unique and personal reasons.
This specific role, did you find that there was a gap between the practice and the policy of the work that you did?
Well, the interesting thing about abortion in the U.S., right, and this was back in the 90s, so today even more dramatic, is that the policies vary state by state. So I was in North Carolina, and we provided abortion services at the clinic until 20 weeks of pregnancy, which meant that we saw clients from many nearby states who couldn't get those services where they lived, but we also had to refer clients to other states if they were farther along in pregnancy than 20 weeks. So the policies exist and don't always take people's lives into account, but we were able to provide, I think, really specialized, individualized care to people in a very calm and professional and friendly environment. And that felt really good.
And then when you did your MPH, you did a fields or statewide field study where you kind of were driving to different abortion clinics in North Carolina and auditing that quality of care. Did that field study reveal anything new to you that was, groundbreaking in terms of your understanding between that gap of policy and practice?
So it's really interesting because I wanted to build out a definition of what quality of care was, using definitions of quality of care of health services that existed, but thinking about how it applied specifically to abortion, where it's because it's a politicized medical procedure, it's still a medical procedure.
Yeah.
Quality kind of goes beyond what you might need in terms of quality if you're being treated for appendicitis, say. To me, the key takeaway is there were clinics who welcomed me, offered me a cup of tea and opened their clinic to me and were very engaged and curious about the project I was doing. And then there were clinics that wouldn't let me come in. And so the thing I always speculate on is, well, what was the quality there? If they wouldn't let me come in, and I understand I was an outsider, I was a graduate student, I had all the official approvals, I had all of the boxes ticked in terms of I should have been allowed in, had I been invited in or able to go. Some clinics just were not interested in anyone querying the quality of services that they were providing. But I did see a lot of people across the state, including in some very conservative areas of the state, near military bases, et cetera, where incredibly kind and talented healthcare providers were providing a very needed service to women and girls.
Traci's MPH thesis took her on a statewide road trip. The idea was to drive across North Carolina to every abortion clinic in the state. The goal? Getting first-hand experience observing the everyday realities of women accessing care and how services were being delivered to them. That exploration revealed the gap between policy on paper and in practice. This fundamentally shifted her way of thinking about what quality means and for whom. On the technical side, you've got clean instruments, correct drugs, but on the personal side, privacy, options, and dignity. And through your exploration on what quality of care meant in terms of this type of service, did you ever come to a more or less concise idea of what that would be like? And I'm sure maybe it's evolved as you've grown in your career as well, but what does that kind of mean? What does that mean back then and what does it mean to you now?
I think quality needs to come from at least two directions, right? There's the quality that you can see that is going to meet certain standards. People are washing their hands, instruments are sterile, the right procedures are being, applied correctly, the right medicines are being given. That's meaningful quality. But if it doesn't feel good to the client, or if patient care doesn't feel good to patients, if they don't feel privacy, it might technically meet some checklist measure of privacy because there's a curtain. But if someone's worried about being heard on the other side of the curtain, it doesn't feel like a private experience to her. If they don't have the option to either invite someone into a counseling or exam room with them, like they're a parent or sibling or partner or whomever, or if they don't have the option not to, right? That, you can be following clinic protocol, and if it's not meeting the needs of the individual, then I think we have a gap in perceived quality, which is different from, hand washing and instruments being sterilized.
Yeah.
So I really think those two things have to come together. And there at the medical care center where I was working, in the clinics I was looking at, and the work I've done since, I try to pay a lot of attention to services and care and information, the whole package, being really focused on the person who's receiving that care.
Yeah, making sure they're feeling mentally and physically safe in that kind of environment as well. And then in 1995, you joined IPASS. It's an organization that
was expanding or is expanding access to safe abortion and contraception in more than 20 countries, which is absolutely amazing. And you stayed for 22 years. 2 decades in like essentially a lifetime in an NGO, honestly. What kept you there and what finally nudged you onward to move and progress past that?
So what kept me there were a couple of things. One, the people. IPAS still continues and exists today. I'm friends with people who continue to work there and a huge alumni association. The people are remarkable all over the world. They are hard to leave. They're very sticky. You start working with them when you want to keep working with them.
It's a good problem to have.
It's a great thing. It's a great characteristic. The other thing that really kept me there, Purva, was that it wasn't one job. So it was one organization. But from role to role, I had such different opportunities, different challenges, different responsibilities. Some of the roles didn't look anything like the others, but every few years I was doing something that was as different as if I had left and gone somewhere else. So when the people are so compelling and the work was so meaningful and the roles were so varied, it was a great place to learn over 22 years. And then when I left, it was really an opportunity to try to hold some ground in my own backyard. It was the time of the first Trump administration. And at the time, I had a teenager and a preteen. I have 2 sons. And I had the opportunity to lead an organization called Shift NC, sexual health initiatives for teens. And it was working in the state of North Carolina where we were living at the time and trying to make progress on access to sexual health services, information, policies, et cetera, that supported young people there. Mm-hmm. And it felt like a really good time to get grounded in my own backyard.
That's amazing. Honestly, your experience at IPAS sounds like the dream. I think everyone hopes for not just the opportunity, but the passion of the people that you work with and for your own passions to be fulfilled in an organization. And then to have like this meaningful kind of send-off of segueing into the next step of your journey. That's amazing. You did mention that, you had a lot of roles and these new challenges while you were at IPAS. And during the stretch of time, you progressed through leadership roles from program officer to executive VP of programs. And you took quite a few bold swings along the way while you were there. What would you consider was the biggest risk that you took at IPAS that ultimately moved their mission forward?
Well, that's a great way to frame it. So I think a risk that both IPAS and I took together was pivoting to expand IPAS's work into medication abortion with pills. So IPAS was actually created in 1973 around a technology called manual vacuum aspiration. It's a small vacuum aspirator that you can use for early abortion or for treating incomplete abortion, treating miscarriage. You can use it for sampling for endometrial biopsies. It's a very useful tool and very useful all around the world. We actually used it at the clinic, the medical care center where I had worked prior to IPAS.
Oh, wow.
But it's very useful around the world. Doesn't require power or electricity. It can be used in community health facilities or by outreach teams. But it was and IPAS at the time was a very technology-oriented organization because that was its technology. But its mission was bigger than that. The mission was access to high-quality services to address the issues of unsafe abortion, right? So both treating complications of abortion and providing access to safe abortion. And the world had moved into this era of medication or medical abortion. So for IPAS to do that, it was a change because it wasn't its history. So it was really willing to define itself a little bit differently, broaden its remit around abortion care. And then leading that effort was truly just a fulfilled passion and dream. Back when I was in college, I did a research project on college students' perceptions and their ideas about medication abortion back many years before it was available in the US, like hypothetical acceptability, basically, because I was so curious about it, so interested, and what would it be like if we had access to this technology here in the US. So to be able to move things at IPAS so that we were expanding access to medication abortion for women around the world, but not just hypothetically, like I was thinking in college, but actually real, right? Like improving the quality of services by giving people choices, increasing access, increasing the cadres of healthcare providers who could offer abortion care through medication abortion. And now, in the US, it's, more than half abortions are provided with medication abortion. And around the world, it's common and it's available and it's safe. It's all the things we need it to be.
Wow, what a great full circle moment for you. I think that's like one of those lasting, when we spoke about this before we started recording, just one of those lasting impacts that you see, it's staying even after your time at IPAS. Congratulations. I think that's really such an amazing, while you said risk that you kind of took while you were there, it's great to see that full circle moment come in your career. This is a good time for us to do our Insight Blitz. It's where I'll ask you questions and read some statements, and you're just going to provide your brief responses. Are you ready?
I'm ready.
What's a skill that you learned early in your career that you still use today?
Budgeting.
Oh, you know what? I am learning this skill right now. I have been told I need to start gaining it as well. Clearly, it's helpful.
You never don't have to do a budget. And I remember when I was hired at IPAS, I remember the person who asked me this question during the interview about what my experience was with budgeting. It was like, well, I, don't default on my credit cards, like nothing, no professional experience. So it was lesson number one, so I could do my job then, and it's lesson forever. Yeah.
Amazing. Well, glad I'm going down the right path right now too then. All right. Quote one statistic that instantly conveys why sexual and reproductive health work can't wait.
You're asking hard questions. I have to choose one statistic. I'm totally at a loss. I mean, my mind is full.
There's too many of them.
My mind is full of numbers. I mean, everybody is a sexual person with their own preferred reproductive intentions, whether that's to have children or not, with whom, when. So I think maybe the statistic is that sexual and reproductive health and rights affect every single human on this planet. So never mind the 1 in 3 over here and the 1,400 per the year over here. It's 100%, Purva. Mm-hmm. Let's go with the statistic that 100% of people need sexual and reproductive health and rights in their lives, and we need to make sure that that's possible.
And yeah, of course, that can't wait. Absolutely. Okay, a quick shuffle here. You're hosting a dinner party with your personal heroes. Who's at the table?
Oh my goodness. Okay, let's invite Ketanji Brown Jackson, because not only is she blazing trails on the Supreme Court, but I had the absolute pleasure of being in her courtroom when I was a plaintiff in a case that she ruled for, and so loved seeing her in action. Let's invite, I've been thinking recently about Alexei Navalny, the Russian opposition leader and pro-democracy freedom fighter. I've been reading his autobiography, and talk about a brave, absolutely brave, powerful person. Mm-hmm. Let's invite Sunny Williams, the astronaut who was on the space station. She's, I actually heard her speak after a film festival viewing of a documentary that she featured in, and love to talk to her some more. I think also, she's someone who's very brave. And let's invite Ellen Johnson Sirleaf, the first woman president in Africa, the first female head of state in Africa, who was president in Liberia. Let's invite her. How many is that?
I think that was 4.
That's 4. Can I invite you? Because you're asking me questions, and if you come to dinner, I can get to know you a little bit better too.
I was about to say I might crash this dinner party. It sounds amazing.
I've been thinking a lot about bravery and people who are bold. So these are the people who are on my mind right now.
I love that.
Brave,
noting all of these people down, I think I've heard a few of them, but some of them are new names, and that's definitely, I love hearing about everyone's personal heroes. Okay, last one. What is the worst piece of advice that you're glad that you ignored?
Worst piece of advice that I'm glad that I ignored. I once got a piece of advice that I actually took and it didn't go well, so I've ignored it since. And it was basically advice that I needed to be more aggressive and just insist to get what I want, because if that's what I needed and wanted, then I needed to stand up for it. And so I went into the meeting about which I got this advice and crashed and burned. So that's the piece of advice I haven't taken since, and I'm sorry I learned the hard way, but I don't I think there's lots of ways to be effective in the world, and being aggressive and pushing my way through, and that means sometimes pushing people around. That's never the way.
Yeah. No, I'd agree with you there. Kind of working in the way that you usually worked, maybe with more power is usually the way I go. Okay, so back to our usual line of questioning. That was our Insight Blitz. I hope it wasn't too bad.
No. I'm
Amazing.
still thinking about if there's another statistic I want to offer you. But no, I think I'm going with 100% of people need sexual and reproductive health and rights attention. So let's go with that.
We mentioned Shift NC earlier on, and you talked about it. So after 2 decades on the global stage with IPAS, you chose to focus on your own backyard, as you mentioned, and focus on adolescent sexual health in North Carolina by leading Shift NC. You kind of mentioned briefly what the aim of what Shift NC was, but if you could give us a quick elevator pitch, what problem did it aim to solve, and how exactly did it do that?
It was really Originally, it was designed to prevent teen pregnancy. Very focused goal. And it was one of many teen pregnancy prevention programs that were launched across the country, state-by-state programs, decades ago. By the time I had joined Shift NC, it was a much broader organization. It was really around sexual and reproductive health and rights, was really focusing on not only health, but also education. So in schools, in healthcare facilities, and reaching young people with accurate information about their bodies, about their health, about their choices. But then depending on what they chose, making those choices safer. So increasing access to available contraception, referrals for abortion services. We weren't a healthcare provider, but we worked with facilities as well as with education programs. And most importantly, perhaps making sure it met the needs of all adolescents, all teens in North Carolina. So you can do programs in schools, but then you need to do programs outside of schools. Perhaps most meaningfully to me, I was just so impressed with this work that my colleagues designed before I got there. It was just such an important project, was a program that brought health education and really rights-based information to teens who were in foster care and in juvenile detention centers, because those are teens that we don't usually think about.
They're usually left behind, for sure.
They're so left behind.
Yeah.
And, sex ed is awkward enough if it's your grade class at school. But if you are in a juvenile detention center and you are in a different facility-based care, or you are in a state-based care because you don't have a family, you need the same things. It's more because you don't have as much of a social network around you.
If IPAS taught her about scale, Shift NC taught Traci about nuance. After 2 decades working globally, she returned to North Carolina as CEO of a statewide nonprofit focused on teen sexual health, championing LGBTQ inclusive curricula and peer education programs. Community voices and grassroots partnerships became her new North Star.
So yeah, I felt passionate about that work. We worked with the North Carolina State Legislature to improve policies and increase funding for adolescent health initiatives. It was a great program.
Yeah, it sounds like it. And I love that you also worked with, obviously adolescent children. They're already a vulnerable group, but there's always an intersectionality there too, where you've got even harder to reach populations within those as well. So I think it's great to hear that you were, working with children and adolescents that were even further vulnerable.
Yes, and working with LGBTQ adolescents.
Yeah.
As well, again in schools, but also making healthcare services safer for them and making information more accessible and more inclusive of their experience. The other thing, and I know I'm going on about this a bit, but the program also encompassed parenting teens. And, often you think about adolescent health programs, that's considered like a failure of the program. Well, we couldn't keep this teenager from getting pregnant, so, oh well. But they have every right to more information and every right to be supported as a parenting teen, still a young person who needs information, has a right to information, has a right to services, has a right to make their choices. So it really was the full cohort of adolescents and with no one left behind.
I love that. Sounds like amazing work. And I mean, you went from IPAS that was working at over 4 continents to Shift NC that was obviously very state level focused. How did that zooming in after the zooming out that you were doing before sharpen or challenge kind of what you brought to your work?
It was fascinating, Purva, the sort of perspective taking. So when I worked around the world, when I traveled to Ghana, or I traveled to India, or I traveled to Ethiopia, people are always pleased if I know about their country, if I could say hello and thank you in their language. I'm interested, and I always am, but no one expects me to just get it, right? Because I am an outsider, and I'm obviously an outsider in those places. In North Carolina, I looked like I could fit in, but I didn't know North Carolina any better than I knew Ethiopia or Zambia or Bangladesh. I did not grow up in North Carolina. My years living there were either during graduate school or while I was working in an international organization. So my attention was focused somewhere else. So I learned a lot and was humbled very quickly by the prospect of working someplace where I was meant to be representing a state that I truly was an outsider to, and I had no business representing. Now, I had a team of colleagues who were brilliant, not all of them from North Carolina, but many. But it is just a reminder, right? Like when my colleagues and I at EngenderHealth now, or at IPAS previously, work in Nigeria, even within communities in Nigeria, you have leaders who are members of those communities, or organizations and local partners who are members of those communities. And in North Carolina, it was just as important, right, for people leading work to be of a place, of a system or institution, of a community. So I think my biggest lesson was that, just because it was in the United States and it's where I was living, didn't make me any more ready to lead, because I really wasn't of the place. As much as I loved it, loving it isn't the same as knowing it and growing up there and having that as part of your own culture and just sort of experience.
Yeah, and sometimes I find that, when it's in your own backyard or a country that you've grown up in, you have to still remind yourself to not come in with any biases or, the knowledge that you already have and come in as just somebody from, outside looking in. Even when we do like work in rural Canada, for example, I've grown up in Canada my whole life, but I have to remind myself that this is still a new environment for me. Even though I've grown up here, and while I understand the general atmosphere and environment, this is not the community I've grown up in. And so there is also that reminder. So I think you framed it really well, that you're still an outsider, even though it could be in the state or the country that you've grown up in. Somewhere in the transition, with Shift NC, you also went back to Stanford and did a 9-course lead professional certificate on corporate innovation and leadership. What fresh perspective did that program give you? And have you baked those lessons into your approach to leadership and culture building since then?
It was amazing. It was during the early to middle part of the pandemic that I decided to do this. And I'd been tempted for a long time by doing an MBA. I mean, I have a master's degree in public health, and I don't intend to go into business, but it was the leadership and sort of systems thinking of an MBA that was attractive to me. So when I learned about the Stanford Lead program, I was excited because it was really all the parts of a MBA that I wanted to do without the parts of an MBA that I didn't feel like I needed for my current job or future professional opportunities. So it brought me into groups and conversations that I hadn't been in before and haven't been in since. Just for example, taking a class in crisis management and working on a crisis management team, like a scenario team where you're all online and messages start coming through and your board chair calls and the media calls, and you've got 8 minutes to do these things and all of this stuff, and the adrenaline is just like coursing through you with people who were all over the world, who had different first and second languages, who had different professional experiences, but we came together as an instant team in that moment to solve a problem. And it was exciting and exhilarating. And I think it's both the skills in crisis management and the ability to form and reform teams across different skill sets and experiences and professions and geographies was just a great sort of touchstone for me, sort of mid-career or whatever I am in my career.
I think it can also be a little inspiring and invigorating that, there are people out there like you who are similarly passionate to work together and, towards this goal in mind. That's really cool. I actually hadn't learned about the Stanford LEAD program, so this is very interesting, especially I think as people who are in MPH and global health fields. I think more and more they're looking into MBAs and things like that. So great to see another alternative that people can consider to kind of build their leadership and innovation, experience and knowledge. So kind of going into now where you are today, in 2018, you stepped into the CEO seat at EngenderHealth, which is a global sexual and reproductive health and rights powerhouse active in roughly 20 different countries. Can you talk more about EngenderHealth and maybe what surprised you the most after you swapped to the state level advocacy and then to a 20 country portfolio?
Yes. So it was exciting to come back from my work at Shift NC to be in an international setting again. And then also, compared to my previous work at IPASS, EngenderHealth has a broader set of program priorities. So in addition to working on contraception, safe abortion, and post-abortion care, we also work on maternal and newborn health. We have decades of experience with addressing the problem of obstetric fistula. We've had a great program that was making cesarean delivery safer. We also have decades of experience addressing gender-based violence, both prevention and response, supporting survivors in a really holistic way. Mm-hmm. And we do all of this with a gender lens, as we call it. Like we're always looking at the root causes, the root issues in communities and institutions and policies and within the media that we can support change so that there is more opportunity for women and girls, for people who are typically underserved by systems to have access to the broad sexually reproductive health care that they want. And it's been an absolute pleasure. It's been 6.5 years, I think. Mm-hmm. And it's been quite a ride with the pandemic and then the USA cuts.
Fast forward to February 2025. After years of expanding programs in 20 countries, EngenderHealth received confirmation of news nobody wanted to read. The USAID had just terminated 3 of their flagship grants. Coming up next, we'll find out more about the ripple effects of these cuts and how EngenderHealth is innovating and mobilizing to sustain critical services for women and girls worldwide. That's next time on the Public Health Insight podcast.
This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art designed for our show by LaShawn Benedict. The Public Health Insight podcast is produced by PHI Media. Thank you for listening to the Public Health Insight podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.